10:04. This is 10:04 a.m. Eastern Summer Light Saving Time. And we are very glad that we could have your participation today during this second part of the Anglophone, the consultation in the American continent about the high-level meeting perspective from the civil society. This has been a consultation running in all regions in the globe and moved by the Civil Society Task Force for WHO. And Pajo is responsible for this presentation. I'll be helping facilitating, but I would like right away to give the floor to the Director, Dr. Ruben Mayorga. Thanks, Ruben, for being with us today.
Thank you very much, Ezio, and a very good morning to everybody that is connected to this call. I would like to start by remarking that global efforts to combat tuberculosis have saved an estimated 74 million lives since the year 2000. However, the COVID-19 pandemic and socioeconomic inequalities have caused reversal of years of progress, and those that have been most affected since the beginning of times had a big burden of this disease during the COVID-19 pandemic. In the latest World Tuberculosis Report, WHO highlighted that for the first time in more than a decade, tuberculosis incidence and deaths have increased. This year, 2023, is crucial for the agenda to end tuberculosis at the highest level. As a matter of fact, heads of state will meet for the second time in September 2023 to deliberate on accelerating efforts to end tuberculosis at the UN General Assembly High-Level Meeting on Tuberculosis. For this reason, the theme of World Tuberculosis Day for this year will focus on the preparation of this high-level meeting. From PAHO, we have made a call to action for member states to promote leadership and high-level action to end TB. And this focuses on the following points: increased investment of resources to guarantee equitable access to TB prevention and care towards universal health, implementing TB preventive treatment options recommended by PAHO and WHO, shortened regimens, rapid molecular diagnostics and tests for TB infection, and research and innovation. And of course, ensuring multisectoral coordination to end TB. Progress in the fight against TB and its causes cannot be achieved through the health system alone and requires strong political commitment at the highest level and strong multisectoral collaboration beyond health and an effective accountability system. I would like to highlight the commitment that exists from PAHO and WHO to strengthen the involvement of civil society in the response to TB. As Ezio was mentioning at the beginning, in the region of the Americas, we are aware of the importance of the participation of civil society and affected communities in the fight against TB, as it is the same in the fight against many of the other transmissible diseases. And as such, we have promoted joint activities with civil society, vulnerable migrant populations, indigenous people, persons deprived of their liberty, among others. As an example of this commitment, the Director General of WHO renewed the WHO Civil Society Working Group on TB in 2018. This is a platform for dialogue and exchange between WHO and civil society. As such, this platform seeks to enhance the collaboration and involvement of civil society and communities affected by TB in the response to this disease at all levels, and to ensure that the voice and vision of civil society is present in the implementation of the NTB strategy and, therefore, in all of the activities carried out by the WHO, such as policy formulation, meetings, events, and this high-level meeting in New York in September 2023. This year, the WHO Civil Society Working Group on TB has proposed holding a series of regional consultations with civil society and those affected to learn about the perspectives of civil society and communities affected by TB, and in compliance with the NTB strategy and the commitments of the 2018 high-level meeting, these consultations will obtain inputs for the preparation of the UN high-level meeting on TB in September of this year. For this reason, in the Americas region, we are carrying out this consultation today for English-speaking countries. As you mentioned, on March 28th, a consultation in Spanish and Portuguese took place. These consultations aim to strengthen our commitment and engagement with affected communities and civil societies in efforts to end TB and take their voices into consideration in preparation for the high-level meeting. The specific objectives of this consultation are to gather views by communities and civil societies at the grassroots level regarding their perceived needs and priorities regarding local and national efforts to end TB. That's the first one. The second one is to document key community and civil society inputs, recommendations, priorities, and asks for the high-level meeting. And the third one is to strengthen engagement between PAHO-WHO, national TB programs, and grassroots communities and civil society as key stakeholders in the TB response. As a matter of fact, we have had some requests from the Spanish and Portuguese speaking groups to keep this consultation mechanism and these meetings that we are having now as follow-up before the meeting in September to be able to document good practices in the TB response by key affected communities so that we can have a repository of good practices for the region. As a result of this consultation in the Americas, we hope to have recommendations for action to be incorporated into the new declaration of September 23 towards the end of TB. That would be my initial thoughts, and I hope that you have a very successful meeting. In the meeting of the Portuguese and Spanish-speaking countries, there was a lot of information and a lot of recommendations that came up. And I hope that this will be the same case for this meeting with English-speaking countries. Ezio, back to you.
Thank you so much, Ruben. That was great. Thanks for the support of PAHO in our region to be doing this. And I wish that we come together with a common view from the civil society in our region, in for the whole continent, for the whole hemisphere, that we have a strong statement for the the multi-stakeholder hearing that will happen in early May in New York, in the 8th and the 9th. So we hope out of this consultation, and then we will we'll gather, we'll merge the presentations and try to have one strong statement that obviously you guys will be critical for helping us doing this. But let's now go into the welcoming words by Dr. Teresa Casaeva, Director of the Global TB Program and Acting Assistant Director General for UHC and communicable and non-communicable diseases. So, thank you.
Dear friends, colleagues, and open.
Ezio, we can't hear. I don't know if it's only me. I'm sorry.
Organizations and homes. I'm Dr. Teresa Casaeva, Director of Global Tuberculosis Program and the Acting Assistant Director General of the Universal Health Coverage, Communicable and Non-Communicable Diseases. Dear friends, as you know, we had the first UN General Assembly high-level meeting on TB 5 years ago, in 2018. And the Political Declaration Committee to strengthen leadership, multi-sectoral response and accountability, community engagement, expanding access to people-centered TB services, and advancing research, development, and finance. Globally, there has been progress, but due to COVID-19 impact, we have regressed. It means that we have to double our efforts to save people's lives and reach our targets. Tuberculosis remains one of the oldest and biggest global epidemics, affecting 10.6 million people and accounting for 1.6 million deaths, according to the latest global TB report. Unfortunately, nearly 40% of people with TB are not reached by TB services. Funding for TB activities remain insufficient. It's time to ask ourselves some hard questions. Why TB, a preventable and curable disease, continues affecting millions, and what we can and must do better. COVID-19 pandemic has reversed, as I told, the years of progress in reducing TB disease burden. Lessons learned from COVID-19 response teach that we need a resilient health system to sustain access to care for people with chronic diseases like TB, even during emergencies, and proved that communities and community-based care are the cornerstone of the healthcare. WHO anti-TB strategy and the UN Sustainable Development Goals emphasizes the role of communities and civil society in ending the epidemic as a major principle. WHO promotes the vision of resilient health systems with the community as it continues, fully aligned with the principle of people-centered care. This is also at the heart of the WHO guidelines on engagement of communities and civil society to end TB, which will be launched in April this year. Community and civil society engagement needs to be strengthened through involving people affected by TB in the planning, decision-making, implementation, and monitoring. Community is one of the major drivers for the multi-sectoral accountability framework. Dear friends, and all participants in this event, to listen to the grassroots civil society and regulators, the UN meeting 2023. One greeting from the next organizations. Acting and assisting director, general Consultation, analytical and business businesses. Dear friends, as you know, the first year general assembly piloted meeting on 5 years in 2018. The political declaration to strengthen leadership.
I'm sorry. I think we have a problem with this audio. It seems that the audio was really low, right? But I can send you the link of Teresa's presentation, but could you, Belkis and Monica, could you hear the presentation, or it was difficult? It seems I saw some people in the chat.
The video, I mean, it was an echo in the video, so
Yes.
we couldn't hear very well, and
Yeah.
it was very low also. So probably, probably it's the best idea if we can share the, like we do with the Spanish session, like the QR code.
Yes.
That
Yes.
way they can.
Yes, I will. I'll share the code afterwards with the participants of this session.
Okay.
Thanks so much, and I appreciate that Teresa has provided us us all in the consultation a message, and I thank Ruben, PAHO team, and Teresa's team at the Global TB Program to be supporting the CSTF effort in this global consultation. So as I said, the objective is to, as Ruben has already underlined, is to have a perspective from the civil society and the achievements in NTB, but the focus of this consultation is to check from your perspective what has being actually reached in terms of from the recommendations that there were given in 2018 and the commitments in 2018 and the recommendations provided by the Secretary General in 2020 on the progress on those commitments from 2018. So this this idea to share this view, I mean, the global TB the global TB program is doing a big effort to underline the presence and the participation of the civil society in all areas, and we are hoping that from our region, as I said before, we can address a message, a strong message in the consultation happening in early May in New York. So this will be also important to document the achievements that we have in the region, and to link to make us working together more in terms of our regional agency. I am very glad PAHO has a very important presence in Latin America, and we hope to put together Anglophone, even Francophone, and Spanish speaking and Portuguese speaking all together in future opportunities. So basically, we are going to divide we have gone through the welcoming words. We'll have now a presentation that I think Monica will run on behalf of Pedro Avedillo, who unfortunately could not be with us for urgent other community commitment in Washington. And following this presentation, we are going to hear from the civil society perspectives about the meaningful examples of meaningful participation by the communities and civil society in TB policy in our region. Following then that, we'll have a discussion, a short Q&A with the audience to hear their perspective, and then we'll do a what we say in Portuguese, a bate-bola, which was a ball game. It's like to play like very quickly, like 1 minute each, that we are going to go through all the 10 recommendations, actually 9, because the 10th recommendation we are not going to discuss, because it's exactly what we are doing here, which is to engage the agencies in this effort to make things run. And then we will have a final discussion, but focusing specifically on the audience perspective or the views from the audience about what messages should be in the political declaration in September, and what are the most important, I would say the 3 most important aspects for guaranteeing high quality, people-centered care in our region. So this will be the last discussion, and I will, without further ado, I will move into our presentations. So, Monica, I think you are going to present, right?
Right. Yeah. Thank you so much, Ezio and colleagues, and thank you everyone for being here. I am Monica Rondon. I am a member of the TB regional team on PAHO in Washington, D.C. And in behalf of Dr. Pedro Avedillo, that is here, he is the advisor of tuberculosis prevention and control and elimination in the UNHT unit in the same organization. I want to welcome you to this event. So, well, as you know, in 2018, it was held at the high-level meeting on the fight to end tuberculosis in United Nations in New York. Just to summarize that participation, we were more than 1,000 participants from 50 countries with head of government or head of states delivering statements. And the main objective of this meeting was encourage the high-level participation to end tuberculosis. Next, please. So from there, we have some United Nations high-level meeting on TV, and there were some key commitments and goals that I think you know very well also. But just to summarize, there were 10 key commitments, and they were related with provide diagnosis and treatment for more than 40 million people that were estimated to occur between 2018 and 2022, including children and people with drug-resistant TB, and also preventing the TB with providing preventive treatment by 2022. We're waiting that for that 2022, 30 million people could receive this treatment, preventive treatment. And I think one of the most, we can say that we want to call to the action to the member of states on a region to increase the investment of resources and to guarantee an equitable access to the TB prevention, and also to care towards universal health coverage. Also, it's also related, these key commitments related with overcoming the global public health crisis, to improve in policies and systems. Next, please. To improve or to implement shorter regimens, rapid molecular diagnosis, research and innovation. And I think one of the most important or that you can help to us to achieve these goals, like civil society, is to ensure the multi-sectoral coordination to NTV, not only at the global and regional level, also to the national and local levels. And one of the other one most important also is promoting an end to a stigma and all forms of discrimination, providing especially attention to this, to that poor people, the vulnerable and communities, especially those who are at risk. So is another kind of key commitments and goals related also with advanced research and innovation, using the mechanisms that and networks that WHO has established at the PAHO also has established in the region. Next, please. So after that, we have the progress of the report of the UN Secretary General in 2020. And they were these 10 priority recommendations that was related also with the key commitments and the goals that were provided. But we just want to highlight not only all that we already mentioned, but also to ensure the meaningful participation of civil society and communities and the people affected by TB. And most in these days after the COVID pandemic, we want to also be sure that we can able to ensure the TB prevention and treatment are protected in this context, or a next or an emergency threat that could be happening in the future. Next, please. As you know, also we have the multi-sectoral accountability framework to accelerate the progress towards the end tuberculosis. This document was published by WHO in 2018, and the aim is to be adopted and used at national, regional, and global levels. This document seeks to accelerate the progress towards the meeting the goals and the milestones of the SDG and the NTB strategy. And we think that is very important in this point, the commitment of the civil society and the all actors or the all stakeholders that can participate make the actions to be held and to achieve the commitments that they are established by this high-level meeting, and also to make sure that all countries can make the checklist for these activities that is implemented in this document. Next, please. We just want to show you here the roadmap 2022-2023 towards the United Nations high-level meeting that is going to be held in 2023, the September, of course. As you can see in the roadmap, we start in 2018, I'm sorry, but we just want to highlight the audience that is going to be held in next May. The audience with the interested parties that is going to be a great opportunity for everyone who can make part of this event to improve or to strengthen the participation and the intergovernmental negotiation with the all countries on the all interested parties who can work in NTV in our region towards the preparation to UN high-level meeting to end tuberculosis that is going to be in September. Next, please. And to finalize only, I want to say that, like I said before, the participation of everyone is required to prepare a successful United Nations high-level meeting on TV, to accelerate the implementation of the multi-sectoral accountability framework on TV, including the high-level reviews of progress. That's why it's so important that in our countries we can make a follow-up of these implementations. Also contribute to the second political declaration of the UN high-level meeting. That is a huge issue, I think, achievement for our region or for the world in TV talking, and encourage the participation of high-level meeting national delegations in this event in next September. So we just want to encourage you guys to everyone to be committed or to maintain committed like as you are until now on these activities and to end to the TV in our region. Thank you so much. Back to you.
Thank you, Monica. Thank you so much for this. This is a good outline so that we can move having this background in mind. So now we are going to jump into our presentations. Thanks Mike, Tina, and Kate to be presenting in about your perspectives from meaningful examples of participation of communities in TB policies. We are going to start with Kate. And the floor is yours. Thank you.
Thank you so much. I wanted, oh great, there's my slide. You guys can hear me, right? I hope so.
Perfect. Yeah. Go ahead.
Beautiful. Beautiful. I am in a soundproof room, so I was hoping that would be all right. So I'm with an organization called We Are TB. It's all made of people like myself, people who had tuberculosis themselves or affected family. We do have a lot of parents of children who have had TB and a few spouses or just other family. We're all in the United States, and we try to support each other and support greater funding for tuberculosis in the United States and around the world. So I love this group, and I'm very happy to kind of talk a little bit about some things we've seen in the United States. You can hit, okay, so some things that I would consider progress in terms of community. And when I say community, I'm talking more about survivor and affected family advocates. You can also use community to mean maybe like people who work in like organizations but I'm talking about people personally affected when I'm using this term, just so you guys know. And so in recent years, we really have seen an increase in people who have had tuberculosis and, these kind of advocates participating in advisory boards, community boards, all sorts of panels, and actually being kind of considered the experts they are and able to weigh in. Like there's just more opportunities than there ever have been before. In the United States, frequently public health programs, when they educate healthcare workers or they do programs about tuberculosis, they frequently will ask advocates like us to come and to speak about their openly and honestly about their experiences. So I do think that helps improve tuberculosis care when someone who's had the disease talks about their care and things that were good and things that were bad. Especially in the United States, where a lot of times we do have a lower incidence of the disease. So sometimes healthcare workers aren't really familiar with the disease and the challenges that people with tuberculosis are facing. So I do think that hearing that personal perspective is very, very effective and helpful. And we're starting to see more tuberculosis survivors, affected family advocates traveling to conferences and presenting on panels there, not just as like, here's my sad story, but again, more as kind of like an expert or as someone with valuable shared experience. And one of the biggest things that I think WeAreTB has done that has helped improve tuberculosis care is we kind of made something for ourselves. I don't know if you guys, just because this is a kind of affiliate with the WHO, someone on their community advisory board, Tenzin Kunar, who's a member of WeAreTB, it was his idea for us to start doing support groups. We've been doing those for now 2 years. We started in November and we've added a second language. We do tuberculosis support in English and Spanish, that kind of social emotional support. And I think that that's been really helpful, not just to help people through treatment, but then also it's kind of a bridge to getting people involved in advocacy. A lot of times people will join our support groups and then stick around with WeAreTB to do advocacy. So it's been really wonderful, and I think one of the best things we've ever done. And so one of the barriers and opportunities to change things, unfortunately, this is the United States, so we always got to talk about money. So money is a huge part of everything. The work that we do, and I think that's mirrored around the world, is poorly funded, if it's funded at all. One thing that I hear all the time and that really makes me mad is people like to say that people get cured of tuberculosis and move on. But a lot of times, at least in the United States, what I can speak to, people finish tuberculosis treatment and they're unaware of ways that they could engage in advocacy. We really try to work on that. We really try to work with public health departments, let them know about WeAreTB, let them know about the things that we offer. But a lot of times you finish up your pills, you leave, and you're not really aware of ways that you could make the whole system better. People in the United States who are diagnosed and treated for tuberculosis, frequently English is not their first language, but it's the language that we use a lot as stakeholders, right? Like that's the language that that a lot of just opportunities for change and opportunities to do things, they're done. These things are done in English, and they're done so that can be intimidating, and that can work against getting community engagement and involvement. Advocates need training. Tuberculosis is a complicated disease. When I was treated for tuberculosis, I didn't understand it fully. I know so much more now about the disease than I ever did during treatment. And I had a long treatment. I was in treatment for a year. But there's just so many layers to it. And to be a really effective advocate, you need someone to kind of train you on it and someone to kind of explain these things to you. Especially if you're going to push for research and development funding, there's a lot of terms and concepts that a layperson doesn't really get, and someone needs to train them. And it's intimidating sometimes to hear things that you don't know, especially if English isn't your first language. Stakeholders and decision makers, as we all know, they're paid to work, and we do our work during business hours, like right now. And affected community advocates, as usually volunteers or people that are paid during a stipend, we got to do things after work or during work hours, like I'm doing now. And so we have to try and find our ways to engage around our lives. Whereas stakeholders, their job is to work in public health or something like that, you know, your life is centered around that work. So we're always trying to fit it in. And I think that that's a challenge that I'd like to work on more. I can go to the next slide. Thank you so much. Okay, so some things that I think would really, that are really important is when we have survivor advocates, that involvement can't be like symbolic. I don't want it to be like a token. I don't want us just being at the table to tell a sad story to make everybody else feel better about the work they're doing. There has to be the real ability to make change when we're involved, and there has to be meaningful engagement that really translates to action. And the work must be compensated. Training for advocacy, that time should also be compensated. And we really, with, you know, just like we're doing now, opportunities really should be made for people to contribute things on their own time, off hours, and virtually. You know, especially for the United States, we're behind the rest of the world in terms of the time zones. You know, we really should be, it's better if things are kind of available off hours or at different hours so that people can participate. And I really do think, just in advocacy in general, information should be presented in multiple languages and as simply as possible. And then there's opportunities for you to learn and dive deeper. But at a first glance, we should really try to just get things out there in as many languages as possible, as simply as possible, just to bring people in and make them feel like there's a space for them. So those were my big accelerators, things that I would like to see. So this is a picture of some members of We Are TB doing advocacy this year. Some of the 3 things for person-centered care that I think are kind of important. People who have TB, like when you're diagnosed, we really need to understand the care options that we have fully, with the ability to ask questions throughout treatment. Sometimes when you first get diagnosed, you get a ton of information at once, and it can be really hard, you know, if you don't have a way to ask questions throughout your treatment. It can be hard to kind of give people that full understanding so that they understand why they're having medicine with side effects and why they have to take things for so long, really to be a partner in their treatment and to really kind of make sure that there is an opportunity to continually ask questions, to communicate your side effects. There are a lot of side effects in TB care, and people should have those side effects taken seriously and with an opportunity to adapt their care so that they're feeling their best. People need good nutrition during TB care. People need to not have directly observed therapy interrupt their employment. You know, we really need to if people have to be watched while taking their pills, then we should be really making efforts to make that as convenient as possible. With the coronavirus, you know, pandemic, we really have seen an uptake in video DOT for people in the United States, which is great, because then at least people can kind of do it on their own time. They're not waiting for someone to come to their home, and they're not going to a clinic. So, you know, we need more of that. If you know, if people have to be watched, make it convenient. People in TB treatment and their families need social emotional support. Again, We Are TB does that, and it's been wonderful. It's been the greatest. But that helps with stigma. And you know, healthcare workers need to treat people with respect and dignity. And they need to make sure that just throughout the whole thing, people are feeling supported, loved, and you know, throughout the whole treatment. I hope I'm not going too fast. Next slide. So the high-level meeting for tuberculosis survivors in the United States, we're really hoping to see you know, participation from our government. We Are TB is a part of a group of organizations in the United States called the Tuberculosis Roundtable, and we try to use policy to increase funding and support for tuberculosis care, research, you know, treatment. And so we're really hoping that we're writing like a letter to the US mission and a couple other high-ranking members of the Biden administration, hoping that we can see some good US government involvement in the high-level meeting. We really hope the United States shows some leadership here. And by showing, one of the ways the United States can show some leadership is by increasing funding to US AIDS TB programs, our domestic tuberculosis programs at the CDC as well. And also, really funding research and development. We really need to see, a new effective vaccine. We really need to see, shorter, better treatment regimens. You guys know this already. Better diagnostic tests, especially for children. Tests for drug resistance that are rapid. The United States should really kind of show these funding levels and hope that to show other countries and kind of encourage them to like match and to give as much as they can as well. There's a bunch of shorter regimens that are available, and we need to expand access to the newer, cooler things we have now. There really have been some great advances, and we need to make sure that everybody has access to them. We really need, even in the United States, sometimes there's things that we don't have access to because of the FDA, but that's a whole nother situation. But we really need to improve access. It's kind of investing in new tools is great, but we need to make sure people can get the new tools. And in the USA, there really should be like a social worker in every TB program. There really should be, better education for both patients and people, families, to help them support them through treatment. We really want to see, just more person-centered care in the United States as well. So that was kind of like my little answer to those 5 kind of points. I hope I didn't go too fast, and I'm happy to hand it over to Mike Freg.
Thank you so much. This was great. Yeah, this was really fabulous. Mike, it seems that you are not going to have a PowerPoint, right?
Yeah, no slides, just me.
No slides. That's good. Okay. That's good. Thank you. Thank you so much for joining us from South Africa. And thanks, Mike, for your leadership in so many areas. And I really love to hear Kate, because I mean, she could be at any part of Latin America hearing her points. I mean, it's so common. I mean, the difficulties that communities affected face are very similar throughout the world, and I'm so happy for your contribution, Kate. I mean, and Mike, thank you so much. Over to you.
Okay, thank you very much. Hi, everyone from South Africa, though I'm normally in New York, and I work at Treatment Action Group, a civil society organization dedicated to ending TB, and one that does advocacy for TB research and quality TB programs and universal access to all the tools we need to end this disease. It's great to contribute to this regional dialogue for the Anglophone Americas. The first prompt to talk about was what progress has been made on community engagement and community involvement in decision-making and implementation to end TB. I think a lot of my reflections here echo Kate's, and actually the first point of progress I would direct attention to is the establishment and growth of We Are TB, this amazing network that Kate and other TB survivors in the United States have put together. This has been a major step forward in hearing voices of people in the United States who have survived this disease in all of its manifestations and forms. And as Kate has pointed out, it's been recognized by TB programs at state and local levels, by our CDC at the national level. And I think having this voice in the advocacy we do with the US government and the work that programs do with patients is really a highlight of the past high-level meeting period. The other thing I'd point to is I think we really have managed to strengthen community engagement in TB research. And this is important for our region because we know that the US government is the largest funder of TB research globally, gives over 1/3 of all money spent on TB research. And we've seen US government agencies that are making TB research grants increasingly mandate or set expectations that all TB research efforts will have a community engagement program, whether that's a community advisory board advising a clinical trial or some other community engagement mechanism. This is more and more a standardized part of the research we do. And we're even seeing TB researchers themselves, when not required to do community engagement, approach groups like ours and ask us, how do we do community engagement? This is important to us. We want to ensure that people affected by TB have their needs and priorities met by the research we're doing. And we saw this happen in the establishment of a new program at NIH called the TB Research Advancement Centers, which are meant to advance basic science and translational science work on TB. And even though community engagement wasn't a required part of this grant program, many of the universities awarded TB Research Advancement Centers have established community engagement mechanisms on their own, which I think is really impressive. So that's, I think, the progress that's been made. We've also seen our Centers for Disease Control, which is responsible for sort of TB standards and program support here, do more targeted campaigns toward particular communities impacted by TB in the United States. A good example is the Think, Test and Treat TB campaign, which is focused on testing for latent TB infection, linking people to preventive treatment, screening for TB disease, and linking them to treatment if necessary, and is particularly targeted toward Asian American and Pacific Islander community and demographics. So I think these all stand out as points of progress. We've also had, though, some barriers for community engagement. And I think we haven't realized the vision of like a fully active community engagement in TB in this country. I think one barrier is just to compare ourselves to other disease programs, right? So for the HIV response in the United States, we have what's called the President's Council for HIV. You know, it's at a kind of presidential level advisory body that brings together different stakeholders. We don't have that kind of mechanism for tuberculosis. We don't have very good visibility at the highest levels of the executive branch. I think we need to expect more of our political leaders, especially at the presidential level. We need to have an advisory committee on the elimination of tuberculosis in this country, as we do for HIV and hepatitis and other things. And we need to get this much higher on the agenda. If you look at our national action plans to combat drug-resistant TB, they're quite old. TB is not well integrated into national action plans to combat antimicrobial resistance. We have untapped parts of the federal government that are not working on TB, but easily could as a part of their mandate. So even though we give a lot of money to TB, more than any other country globally, there are a lot of pieces of our government that aren't yet supporting this fight, but should be. And one example is BARDA, which of course was so instrumental in accelerating the development of COVID-19 vaccines. TB is within BARDA's scope, but BARDA has not spent any money on tuberculosis. So I think there are these examples where much, much more can be done. And one thing I want to point out is that it's really nice and good to have this consultation hosted by PAHO and WHO, but we need the US government to hold a national listening session or stakeholder consultation ahead of the high-level meeting for TB civil society groups, for state and local TB programs, for TB survivors in the United States, to ask us what our priorities are so our government can represent them at the high-level meeting. And this is a meeting that could be organized by Health and Human Services, which brings together CDC, NIH. It could be done in conjunction with the State Department, USAID, and the US mission to the UN. And I think the fact that our government hasn't proactively set up this kind of listening session or meeting to help its preparations is a point where we're lacking and should expect more. If we look now at going forward, what needs to be done, you know, I think looking at the TB epidemic in the United States, we really need better data on TB and its disparities. I think the challenge for us in eliminating TB here, even though we're a low incidence setting, is going to be how do we do this last mile work? You know, in some respect, the easy part has been done. We brought TB cases down to historic lows, and it's really now about doing the hard work of elimination. And, you know, preliminary data that CDC has released on a kind of state of the TB epidemic in the United States indicates very clearly that most cases of TB here occur among people who are not born in the United States. They immigrate to this country. So that already tells us that our TB programs need to be, as Kate said, multilingual, multicultural in their outlook. We need to be reaching into immigrant communities and making sure we're doing that in a way that respects human rights. If we look at TB among people who are born in the United States, and don't immigrate to this country, we see great disparities with higher TB case rates and incidents among Black Americans, among Hispanic Americans, and among Native Americans and indigenous communities. And I want to point out this in particular because I think CDC did a really nice analysis recently of TB incidents among indigenous persons from 2009 to 2019, and it found a higher prevalence of underlying chronic medical conditions and a TB incidence rate that was at least 10 times higher among American Indian and Alaska Native populations than among white persons in the United States. So this tells you a little bit about the disparities we're facing here in our TB epidemic. They mirror the kind of inequities and inequalities in our American society overall. And we really need to have an equity mindset to our programming and the community involvement that we do. And I think part of it is going to be solving underlying challenges like access to healthcare in this country. We have a privatized medical system for the worse, and the TB program is somewhat unique in that it's actually a public health program. And I think that's why it's been as successful as it's been. And we need to make sure that we strengthen public health programming and invest in our TB programs and do so with a disparities mindset. So that would be my first priority for people-centered care going into the high-level meeting. I think we also really need to look closely at quality of care in our setting. If you look at the statistics, some of which are now years out of date, a lot of people treated for TB in the United States have their treatment extended beyond 6 months. And I think that, sometimes this is medically indicated and necessary, but a lot of this should be taken as a sign that our programs are not performing as they should be. Most people with TB should be able to be successfully cured within 6 months. That's true if you have drug-sensitive disease. It's now true if you have drug-resistant TB with newer regimens. And for drug-sensitive TB, we now have a 4-month regimen. And so if we're seeing a significant portion of people with TB having to extend treatment to 9 months, 11 months, or even beyond, we need to be asking ourselves what's going wrong and what can we do differently. And we also need to be scaling up access to these shorter regimens. And this brings me to another challenge, which is that paradoxically, the United States now has worse access to new TB drugs than most high TB burden countries. And that's because drugs like Delaminid, have not been registered with the US Food and Drug Administration. It's because formulations that are patient-friendly of rifapentine and isoniazid, which we need for our preventive TB treatment regimens, 3-HP and 1-HP, have not been registered with the FDA. And our government has not created a mechanism by which we can buy these drugs from quality-assured suppliers who have WHO pre-qualification. And so our TB programs struggle every day with drug shortages and stockouts. I was speaking last week with TB programs from different US states that are having trouble sourcing isoniazid, that are facing month-long shortages of rifampicin, that are noting price increases on rifapentine, and are struggling to get drugs like ethionamide, which was needed to treat a child with TB meningitis, and that drug wasn't available. TB meningitis in a child is a medical emergency, and the fact that we can't get the drugs we need to treat it really should make all of us feel ashamed. And it indicates a huge systemic problem with TB drug access. And it's going to require a legislative and a regulatory and a policy solution altogether. And we need to ensure that the United States government goes into the high-level meeting not thinking that TB is solved here and that we're just a donor country helping other countries. We have serious problems of our own, and that needs to be a part of the commitments we make to ending TB globally. So part of the commitment I want to see us make at the high-level meeting is to solve the TB drug supply challenges in the United States, even as we support universal access to drugs globally. And I would also like to see our government commit to funding the research and development we need to end this disease, and that includes putting money forward to accelerate the development of new TB vaccines and to making them universally available to everyone. So those are just a few of the reflections that I have to kind of open our meeting and discussion, and hope that that's useful. back to you, Ezio.
Thank you so much, Mike. This was really brilliant. I have been trying to take notes, but it's yeah, it is fabulous to see your remarks and Kate about the progress in terms of CE programs by US funded initiatives. But it's in your remarks about the consultation in your country and how this can be improved, like how services can be improved, is really super important. Thank you so much. This was brilliant. It will help our discussion. So I'll hand over to Tina from Canada. Tina, over to you.
Hi, good morning, everybody. My name is Tina Campbell, and I'm talking to you today from Treaty 6 territory in northern Saskatchewan, the homeland of the Métis. So I'd just like to acknowledge that before I get started. Professionally, my role is a tuberculosis advisor for Northern Intertribal Health Authority, which is an organization that serves First Nations on reserve communities in northern Saskatchewan, and we have about 33 of them. I also sit as co-chair for Stop TB Canada, which is who I'll be kind of representing throughout this, this discussion this morning. So I'll start by talking about our successes based on Stop TB Canada engagement. So although I do not represent the perspective of all civil society organizations working on TB in Canada, I can speak to the work of the Stop TB Canada network, which I am a part of. Stop TB Canada is a network of individuals based in Canada who are all committed to ending TB and works to raise awareness and to generate the political will needed to end TB in Canada and abroad. Some civil society engagements that have been successful over the past couple of years, led by Stop TB Canada, include a survey report on the impact of COVID-19 on TB programs in Canada to fill the gap in delayed data and help inform the TB response. So Stop TB Canada surveyed TB program leads and staff across the country to gain anecdotal input on how the pandemic was impacting TB programs. The report found that across all metrics, COVID-19 was devastating to TB programs in Canada and was seen in reports around the world. Stop TB Canada also aims to hold the government accountable to past commitments, such as to TB elimination in Canada and abroad. Last year, we launched a Canadian TB tracker to provide transparent tracking of progress towards targets to which Canada has committed, and hold policymakers accountable for progress towards these goals. Part of this advocacy includes direct engagement with parliamentarians. Stop TB Canada meets with members of parliament to increase their awareness of TB and gain their support. We are continuing to build parliamentarian champions who are standing with us in our mission, such as this image on the slide here of Member of Parliament Gary Vidal, who raised the issue of TB in the House of Commons on World TB Day last year. So Gary Vidal is also the Member of Parliament for the region that the population I serve as well. So that was very great to have his support. Another central objective of Stop TB Canada Network is to mobilize communities affected by TB in Canada. In 2021, the network launched TB People Canada, which is a network for people affected by TB in Canada intended to connect people with similar experiences, offer them support, as well as provide them with opportunities to engage in advocacy and inform the TB response that directly affects them. The community includes members who were diagnosed with TB outside of Canada, which helps to inform our global advocacy as well. Making this global to domestic connection is critical to gaining political support, as it demonstrates the value of investing in TB, which is not a disease of somewhere else, but a disease of everywhere. And lastly, the Stop TB Canada Network takes part in resource mobilization efforts to ensure that Canada is contributing its fair share of funding to the fight to end TB. For example, last year, Stop TB Canada joined a coalition of 14 organizations across Canada to advocate and support for the Global Fund to fight AIDS, TB, and malaria's 7th replenishment. These efforts resulted in Canada meeting its fair share and demonstrating its leadership on the global stage with a $1.2 billion pledge. Next slide. So apart from the work that Stop TB Canada engages in, and Stop TB Canada is a network of volunteers. So we actually do this aside from our full-time positions. Canada has apart from the work that Stop TB Canada engages in, Canada has made meaningful progress to involve TB affected Inuit communities. The government of Canada has worked with Inuit Tapiriit Kanatami, or ITK, which is the national representational organization for Inuit in Canada, to develop an Inuit-specific tuberculosis elimination framework. Given that the incidence of TB shouldered by Inuit populations is nearly 300 times higher than the rate in non-Indigenous Canadians. So this is critical to making a meaningful difference for this affected community. So the Inuit population take up, they're out over 4 regions, and they take up Northern Canada, the Arctic region. And that's where I started my career in TB back in 2010. So I've been working in TB consistently since then. With the Indigenous population, we have a high burden of disease as well in my region. And we only take up about 5% of Canada's total population, but we experience the high rate of disease and TB-caused mortality. And with my personal experience too, with working with Stop TB Canada, I have, I'm Indigenous myself, I'm of Cree ancestry. So providing that space as well and opportunities for me to advocate for Indigenous communities that are affected by TB has been great. I've gotten good feedback in various discussions, and as this one is an example as well, so I'm very honored to be here. Sorry, oops. Okay, obstacles, yeah. So in terms of obstacles, issues with TB data in Canada prevent a significant barrier. Canada does not have an adequate TB surveillance system in place, and this prevents adequate monitoring and evaluation, which is evident during the COVID-19 pandemic, as we really didn't know the true impact that the pandemic was having on TB programs, because we didn't have that baseline data to compare to, nor did we have the updated data to see what was happening at that time. So even before COVID-19, Canada lacked necessary TB data, and the data that was available was not timely. For tuberculosis data published for reporting years covering 2000 to 2020, the average delay in publication was 25 months, with minimum delays over a year. Without timely analysis and reporting, annual reports do not reflect contemporary context and have minimal application to developing strategies for prevention. As a practical example, the national impact of the COVID-19 pandemic on tuberculosis in Canada could only be evaluated more than 2 years after it began. Data sharing limitations between levels of government are also a major challenge, as there are barriers that impede communication between jurisdictions. TB is an issue that many departments and jurisdictions are involved in because of the structure of how Canada funds and implements healthcare. So based on this, there should be greater effort to ensure smooth communication between departments, jurisdictions, and levels of government. And lastly, the data that is available is not adequately disaggregated. This means that we don't have all the information about the people who are being reported to have TB in a given province. For example, BC doesn't report their Canadian-born cases to Public Health Agency of Canada by Indigenous status, and this impacts the interpretation of the burden nationally. So in terms of what is missing to accelerate community and civil society involvement, there is a key group of people affected by TB in Canada who are continuously left out of conversations about TB elimination in Canada, and that is the migrant population. So newcomers make up 70% of the amount of people with TB in Canada, and therefore should be consulted and meaningfully engaged in TB policy development. Another gap is the fact that there is no single entity responsible for coordinating the TB response in Canada. The currency system is very fragmented, and as I mentioned before, this results in miscommunication and a national response that is not what it could be. We are therefore calling for Canada to implement a national TB elimination strategy developed in partnership with the provinces and territories who carry out the majority of the TB prevention and care services in our country. And with Indigenous leaders and TB affected communities, this strategy must include commitments, guidelines, and the funding required to improve TB screening strategies among high priority groups, address the social determinants of health and barriers to TB care, improve access to essential medicines for TB treatment, implement a timely and robust TB surveillance infrastructure, and adopt accountability, monitoring, and evaluation measures for TB program. And lastly, funding remains a critical gap in our ability to end TB, and Canada must commit to the funds necessary to follow through on its commitments to TB elimination. So funding for programs, that affects TB care positions. So if there's not enough funding for TB programs, then we won't have those bodies to provide TB care. And as you are all very aware, one client with active TB requires, quite a big collaborative effort and a lot of resources. So that's something that we really. So to conclude, we are calling on the political declaration to ensure that people in communities affected by TB and at risk of TB are central to the TB response. Development of national plans to eliminate TB, and commit to sustainable and sufficient financing to end TB. For example, to fund the development of essential new tools to end TB and to ensure equitable access by closing the gaps on TB diagnosis, treatment, and prevention. And critically, all of these commitments must be based on concrete benchmarks, and progresses should be reviewed in 2025, halfway to the next UN higher level meeting and 5 years ahead of 2030. I look forward to the discussion. Thanks for having me.
Thank you. Thanks for being with us. Thank you so much. This was really impressive. And again, how many similarities we have. And with Canada, we also share the same system of universal access that you guys have in Canada, but I see similar problems with that. And we should discuss also how Brazil is organizing some consultation and participating in some meetings. So it's quite exciting to have this perspective from Canada. Thank you so much, Tina. So let's go for our Q&As. The floor is open. Belkis and Monica, I think anyone can just open the mic and speak, right? Or is there any burning question that you have that you would like to jump in? I see Maggie has written from WeAreTB lots of good talks. Maggie would like to start. I think you can only, you just need to open the mic, if I'm not mistaken. Well, if Maggie is not saying herself, I will, oh, Surette, please.
I thank you. Thank you for the presentation, the good presentation, and the welcome host. And my question, I'm from Haiti, and I'm with the civil society, the Forum of the Civil Society. And I really like, I thank Dr. Jeffra who invited us to this meeting. So it's very important for us, for the civil society, to see how we can get involved in TB, because in Haiti, we have some kind of activity that they left behind the civil society. So I'm very happy. And my question is how you can collaborate with the Forum of the Civil Society in Haiti to get involved and to work closely with you, all the partners, all the stakeholders, to have a better response for TB in Haiti. Thank you.
Thanks. Thanks, Surette. We will get more comments or questions, and then we can open the floor to the speakers to respond. Somebody else would like, I'll invite again Maggie, if you would like to. Well, Maggie wrote that reasons why we should work on increasing global funding, not only towards prevalence vaccines, research and development, or mental health related to the known most affected areas in the world, but for all programs, institutions of our communities in the world, bridging the gap. There is a high correlation between what is happening in the States and the reality overseas. Definitely, Maggie, you have a point. And I think that what Surette just brought, it's pretty incredible that we have so similar obstacles, and we face some difficulties which are very correlated. So I think that just to anticipate Surette's question, I think it has been a long period of community engagement that we remember that we started with Treatment Action Group. We organized the first international community engagement, community mobilization of AIDS, HIV and AIDS advocates into TB back in 2002. So it was 21 years ago. I was already doing work in Rio, starting the social mobilization here on TB. So it's a long way, but the progress has been tremendous because we started from nothing, from scratch. And the progress has been really tremendous. So I believe, Mike, I would love you to hear your perspective. Please jump in.
Yeah, thank you. Just reflecting on the question about involvement from Haiti and how that can happen. You know, I think there are lots of ways. One really concrete idea I had is that the Centers for Disease Control in the United States has a TB research network that has done really important clinical trials of new TB drugs. And it's called TBTC, the TB Trials Consortium. And they actually have a trial site. One of the collaborating sites is in Haiti at the Guesquio centers. And I coordinate the community advisory board for this network. And we would love to have a member on the community advisory board from Haiti. We don't have anybody at the moment, but to kind of broaden our regional representation, we have a representative from Peru. We have representatives from other regions of the world, and I think it'd be wonderful to add somebody. So maybe we can follow up directly about the possibility of that. And I think it's an opportunity to really have an influence kind of on the TB research that is being done in our region from a community perspective. So that's one concrete idea. Thank you.
That's super concrete, and I definitely support this idea. Surette, let's put you in contact with Mike, and then I mean, you can share over the chat box the email. And then we will be glad also to share with you later if that's not possible now. But definitely that would be a great way to engage Surette, people from Haiti and start a mobilization. And with the leadership of Mike, you will be in super good hands. Thank you so much. Tina, I would like to pose also your question to you regarding the indigenous people. how do you think this, because there is an incredible similarity between the fact that indigenous people are 300 times more vulnerable than the regular population. And it's very similar to Brazil. I mean, I even think that Brazil is a bit higher, I have to consult, but it's around 300 or so. So it's very similar. But the point is, like, we haven't seen, I mean, an opportunity like we are having now to have you as a community leader and somebody who is visible in Canada, speaking from the communities affected and most vulnerable into this discussion. So how do you think we can progress in terms of having more indigenous people who, I mean, the indigenous people, like some other special communities, are far more vulnerable. I mean, I think above the indigenous people, only people who are in prison. At least this is like here in Brazil. I mean, you have the most vulnerable among the HIV and AIDS, and then people living on the streets. I mean, and then we have indigenous people, and then we have people in prison, which is like 1,500 per 100,000 inhabitants. But how to increase the original community's participation into this discussion and policy making?
Yes, thank you for that that question and comment. So my experience with TB, like I said, it's over 10 years working in various Indigenous communities. I've also been diagnosed with TB myself and went through 9 months of DOT twice weekly treatment back in 2010 when I started working with TB as well. So I have that experience as a patient as well. So I think having that experience is beneficial when I'm trying to relay, you know, just how complex TB care is when I'm talking to any form of leadership. With Indigenous people, you know, because of the historical treatment of TB in residential schools and TB sanatoriums and Indian hospitals and any institution, the Indigenous population has this hesitancy to accessing healthcare to begin with stigmas attached to TB, a lot of negative feelings towards TB. I've had family members that have attended TB sanatoriums, and it's very hard for them to talk about their experience and to talk about tuberculosis at all. So really building that trust through leadership. People need to address and say, hey, we realize that this is still an issue because TB is you know, a result of or can be increased through, you know, the social determinants of health. And many remote communities face inadequate housing conditions, with poor ventilation, and that can increase TB transmission. And nutritious food and access to safe drinking water are either unavailable or too costly, which affects the health of individuals in these remote communities. Also access to care, quality and timely care. When I worked in the Arctic, they had health centers and they had, you know, X-ray units in every health center, which I thought was amazing, but we needed people to be able to use those X-ray machines. And sometimes we had to fly people out of communities to the nearest hospital. But in Saskatchewan, our organization, the health centers aren't equipped with X-ray units. So our organization has 2 portable X-ray units that we bring to the community, and everybody is always grateful whenever we have those mobile X-ray clinics. So, you know, just creating that access for them is building, you know, our relationship with our community members as well. There just needs to be, you know, a collaborative effort across with like I mentioned in the slides, provincial, territorial leadership, federal leadership, because people do think that TB isn't a thing. You'd be surprised on a daily basis how many people are saying, whoa, TB is still around. And sometimes they'll see things in the news. And Stop TB Canada too is great at networking and looking for opportunities to spread awareness. So I've had, multiple opportunities to kind of bring these issues to the forefront and talk about the issues that we're still facing, because really we can't eliminate TB if we don't change our housing conditions in our remote communities. So that's a huge thing that we need to concentrate on, and everything, will require a lot of funding and resources.
Yeah, definitely. I think this has everything to do with the multi-sector approach that WHO has been insisting in these last many years. I mean, we won't be able to move with anything if we don't have a concerted action from different ministries, and which is like housing, transportation, and social security, and many aspects that involves the TB affected populations. I mean, in Brazil, I mean, the services were sometimes often interrupted or non-existent in some tribes and some communities in different parts of the country due to the policies of the last government, which was really horrendous. But we are getting back to that. But having the leadership from indigenous people is absolutely crucial, and we also have to improve in this computer-aided diagnostic with this mobile X-ray machine and all the tools that we can apply for regions which are difficult to reach. I mean, because the Canadian territory is tremendously big, and it's very hard sometimes to reach out to people. So that's something that we have to have in mind. I'm happy that Surette has shared the connection Alberto did. Thank you, Alberto, and Alberto did a brilliant presentation in the Spanish. And he has also shared the rights of people affected by TB, which is great. Kate also highlighted that we really need to treat families and communities with TB not as individuals, but without the right funding, it's always going to be putting out fires, not focusing on prevention, and that's absolutely correct. I have the good news this morning that it was published today in Brazil, a new legislation on cooperation among ministries to end TB. So this was something specific that was published today. So it's now, as from today, official in Brazil. But let's hope that it's really functional, because in the last administration we had an agreement of social protection and the Ministry of Health, which just stayed in paper and was presented like a good outcome, but that has not represented any benefit to the people affected. What we want at the end of the day is that people who are vulnerable and people who are affected have the proper care. So let's move to our quick discussion on the 10 priorities, the priority recommendations by the Secretary General in 2020. So I would like to hear from Tina, Mike, and Kate about how do you think that this has progressed in our region or not. So I will just read the first point, and then Mike and Tina can respond. So the first recommendation by the Secretary General was to fully activate high-level leadership to urgently reduce the number of TB deaths and drive multisectoral action to end TB. Mike, over to you.
Okay, thanks. And I know Kate had to drop, so if you want me to take her place for some of the others, I'm happy to do that, or maybe you've heard
Please.
enough from me already.
No, please do.
Okay. So, on this fully activate high-level leadership, I'd say it's not yet fully activated at the highest levels. As I pointed out earlier, I think in the United States, we have yet to see TB really take a place high on the political agenda, especially in our executive branch and with our president. So President Biden, doesn't have a council dedicated to ending TB. His attendance at the high-level meeting has not yet been confirmed. We did not have the last US president in 2018 attend the high-level meeting, which may have been a blessing, honestly, based on the leadership in place at the time. But, I think this time around, we do want Biden there. On the other hand, he has committed to global health. We hosted Global Fund replenishment, and that needs to be recognized. But I think we need to expect it to go beyond that and to see continued engagement at that high level. That's it.
Thank you. Tina, over to you.
Thanks for that, Mike. So in Canada, we, like we had mentioned in our slides, Stop TB Canada is really pushing, towards building relationship with parliamentarians. Every year we reach out to members of parliament and, ministers in hopes to get their engagement in all these various, urgent issues. We unfortunately have, seen a drastic increase in TB cases in our region, Northern Saskatchewan. So, really bringing that to light, and we're short-staffed everywhere too. So when I say that, getting the attention of leadership and everything, when you hear the term outbreak, people kind of, panic. So having the ability to respond and to help the communities is really critical, but we can't do that without upper leadership and funding and support that way. So, and I think it's that way throughout Indigenous communities throughout Canada. And of course, addressing our immigrant population as well.
Yeah, and to create and to trust, and build trust, as you said in your presentation. This is the governmental leadership is critical. The second point by the Secretary General was to urgently increase funding for essential TB services, including health workers. Over to you. It will be just you two because Kate had to leave. So. Mike, if you want to start.
Sure. I think here we've made maybe a little bit of progress. In the United States, a long-term advocacy goal among TB Roundtable and other partners has been to increase the budget for TB that the domestic TB elimination program at CDC has. It has been stagnant at the same level for many, many years. And we know that a flat budget is really a falling budget, especially against inflation. We have not seen the sizable increase in the domestic TB budget that we've been asking for. Congress has not made that money available. And I think this is part of the reason why we haven't fully activated high-level leadership, because we do expect that our Congress can do more. On the global side, we have had better luck and seen more commitment to expand U.S. Commitment to TB services and TB research, particularly at USAID. We've seen PEPFAR, which is supported, of course, by the US government and the largest bilateral global health program in the world, do much more on TB, especially TB preventive treatment for people living with HIV. And I do think that the kind of truce that was brokered at the Global Fund to have TB receive a greater share of money raised above a certain threshold is also progress in this regard. So I give this like a middle report card, I guess, like a kind of B- perhaps.
Yeah, I like that. Tina?
Since 2015, Canada has provided a combined amount of 5.1 billion to reduce tuberculosis, provide non-insured health benefits, and support mental health care in Inuit communities. Please note that this is combined and not exclusively to TB. Canada's federal budget in 2023 has set aside 16.2 million over 3 years, beginning in 2023 to 2024, for interventions to reduce rates of tuberculosis in Inuit communities. This is roughly a quarter of the money needed to eliminate TB in that region. The budget also has no mention of resources for TB elimination in newcomer populations who are also disproportionately impacted by TB.
Thank you. Let's talk about to advance the universal health coverage to ensure that all people with TB have access to good quality treatment, also overcoming challenges related to unreporting. Mike?
Well, we are struggling to attain universal health coverage in the United States with our privatized system of health insurance. The Affordable Care Act has gone a long way toward expanding coverage, but not completely, and a lot still depends on the state that you live in, and particularly if your state government has opted to expand Medicaid coverage, which covers many of the groups that are most at risk of TB. The TB program, as I mentioned earlier, is still largely a public health program and sort of an exception, and I think that's a part of the success that we've seen. I think we do need to put more money into the program. We need to ensure that it's reaching all the communities where TB is present and where we know access to health services is a challenge. And as I said earlier, I think really a key here to ensuring access to good quality treatment is solving the drug supply challenge that we're facing and that's shared also by Canada. And I think that kind of low incidence countries coming together to figure out how do we ensure that we have access to the best available TB treatments that are born through the research that often our governments are the one doing is going to be a key priority if we want to end TB in the next decade.
Okay. Thanks, Tina.
Yeah, so to work towards TB elimination, where Canada has universal health coverage, but as I mentioned too, remote communities don't have the resources to screen TB properly. Things have to get sent away. Clients have to go to neighboring communities to get screening completed. It will really take that provincial, territorial, national TB elimination framework because we need to enforce, TB education in our healthcare education because unfortunately we're starting to see TB in places we haven't seen, in many, many years, and that's more in city centers as well, throughout remote communities. So, and there's a lot of transiency, especially in southern Canada through provinces. So having that direct, procedure of how and who to find, and really every healthcare practitioner should automatically think TB as a differential given our current, state in Canada with TB, especially in Indigenous communities.
Mm-hmm. Yes, thank you so much. To respond to the MDR crisis and to end persistent gaps in its treatment. Mike.
I think MDR-TB is still a crisis. There's still a huge diagnostic gap and a treatment access gap. And it's really a global crisis. I think the bright spot has been the development of shorter all-oral regimens to treat most forms of drug-resistant TB. Honestly, a huge advance from where we were in 2018, when we were still fighting to get rid of the injectable drug agents that caused so many people to lose their hearing. And now I think the challenge is really about scaling these 6-month regimens based on bedaquiline, bertomanid, linezolid, with or without moxifloxacin. And part of that is going to be broadening access by bringing down price, by ensuring access to generics, by ensuring that we have the flexibility in countries' approaches to intellectual property management, to broaden access to generic medications and have a stable supply of these drugs, and then ensure that they're delivered in a way that support patients to complete treatment and that come with psychosocial support, mental health support, counseling, and all the other things that are necessary beyond just access to drugs alone. So I think there's been progress on the innovation side, but I think that in practice, we have much farther to go on MDR-TB, and what applies globally applies in our region.
Tina.
I just have to make a brief comment before I contribute to this question. It's always interesting to sit on discussions like this because, you know, while you're deep in your TB care in your own region or wherever you're working, you're not aware that, you know, other places in the world are experiencing the exact same barriers to TB care, and you kind of don't feel as alone when you hear that. But it's really unfortunate that we're all experiencing the same kind of thing. So in terms of this question, so Canada is continuing difficulties accessing MDR TB meds in a timely way, as many are not licensed in Canada, and the workarounds are very cumbersome. About 20 to 25 people with MDR TB are diagnosed annually across the whole country. And a federal initiative exploring ways to improve TB med access has begun in our country.
Thank you. To make dramatic use of the provision of preventive therapy, preventive treatment for TB. Mike, your perspective.
So this is where I think we actually made a lot of progress. You know, the only indicator in the political declaration from the last meeting that we met was the goal to give TB preventive treatment to 6 million people living with HIV. Now, I think that indicator was probably set too low, and that's indicated by the fact that we exceeded it by millions of people. But still, I think that really stands out as an accomplishment. We took something that was long known, which was that preventive treatment saves lives among people living with HIV, but rarely practiced. And we really turned it around. And I think what enabled that was the use of, again, innovation, these short course regimens, moving away from long treatment courses of daily isoniazid. But there are a lot of gaps here. We did not give preventive treatment to nearly enough children who are exposed to TB at home. We did not give preventive treatment to other household contacts or close contacts of people with TB, where we made basically no progress. And so we're very far from the overall goal of preventive treatment, which was 30 million. On the other hand, we did over this period manage to greatly increase the supply of these shorter regimens that I mentioned. And so I think if governments commit to preventive treatment, the market will be more supportive than it was in the previous period. But again, the US and Canada are going to struggle to access these shorter regimens because of the drug challenges that Tina and I have cited already. And I just want to point out that in the United States, I think we really need to pay attention to prevention. One worrying statistic in the CDC data is that TB incidence actually increased in the United States among children who are less than 4 years old. And we know that TB among young children is a kind of bellwether or an indicator of TB among adults in their life. And so if we see increased TB incidence among young kids, even if it's just a small signal, that's something we really have to take seriously. And it indicates that our prevention program is not nearly comprehensive enough because no child should be developing tuberculosis. And so I think for us in the USA, this is something we really need to pay close attention to because the data are already telling us we may have a problem here. Thanks.
Thank you. Tina.
Just adding on to Mike's comment, in 2022, actually, our region experienced more than half of the cases in the pediatric population last year. So that's very, very concerning to us. And of course, you know, TB in children can become an emergency if it's not addressed in a timely manner. So, you know, when working with remote communities, that's often very difficult, but we try and make, you know, problem solve and get those kids out and assessed as soon as possible. But it's all extremely hard when you don't have healthcare practitioners aware of TB or not even aware to screen or think about that as a differential, even in communities that have declared outbreaks. So that education there is a gap as well. LTBI, so provision of preventative treatment for TB. So we're way underdeveloped in Canada. LTBI screening is strong for household and other close contacts and healthcare workers. And through uptake of LTBI treatment is variable. Screening for other groups that are at risk is not widely done. Major expansion of a publicly funded IGRA testing would help a lot. Rifapentine is not licensed in Canada. Sanofi has not applied and access is limited. So ability to scale up 3HP is currently limited as well. And of course, with our Indigenous population too, there's a huge pocket of LTBI, people who have LTBI that have not been treated or may have been treated in the past with not adequate regimes. And we can't eliminate TB if we don't treat those LTBI as well.
Thank you. And I would add to what you guys said, the fact that we are living the results of a unbelievable campaign, anti-vax campaigns, so that many people reduce it for the coverage of BCG for small children. And BCG at least protects small children from meningitis, which can kill the child in 3 days. And it's really important. And we had a fabulous coverage in Brazil, was almost 100% in early years, and now it has reduced it, and we have seen this reducing all over the world. As a result of this campaign, and we have to work together on this preventive therapy, because this is critical to reach the NTB targets. So let's talk about to promote the human rights and combat stigma and discrimination. How have we progressed so far?
Just picking up where Tina left off and on rifapentine, and especially its importance for bringing 3HP to Indigenous communities.
Yes.
I think this sort of brings us to the human rights question, because of course, one of the early implementation studies demonstrating the value of 3HP and rifapentine for prevention was done among Canadian Indigenous communities in Nunavut. And that was a program that they designed themselves, and they even refused a donation from Sanofi and bought the drugs on their own. So Sanofi's failure to register rifapentine with Health Canada and make it available, I think, points to this emerging human rights issue, which is that we have a lot of scientific progress against TB, but we have very unequal access to its benefits. And so the human right that I want to highlight at the high-level meeting is really this human right to enjoy the benefits and applications of scientific progress. And that imposes a series of obligations on our governments. They need to invest their fair share into TB research, which is a priority for both the US and Canada, we've heard. They need to make the benefits of that research available equitably to everybody who needs them and can benefit from them. And they need to conserve those benefits or make sure that they're available for future generations and people tomorrow. But the conservation can't come at the expense of access to people who need that innovation today. And so when we see programs ration the use of new TB drugs, like withholding bedaquiline because they're worried that it won't be available tomorrow, I think we really need to say conservation does not mean withholding access today. We need to figure out a way to ensure universal access and ensure that future generations can also benefit. So for me, the human right issue is really one around innovation and access. And I hope member states take that forward in the deliberations.
Thank you. Tina.
Promoting human rights and combat stigma and discrimination. So I had mentioned the historical treatment of TB in Indigenous populations and that mistrust for any institution that is, present today. I think that, the, basic access to these medication, like we said, rifapentine is not licensed in Canada. So when you're having these conversations with clients and saying, it's, you know, we recommend it's best that you treat this LTBI. However, with this medication that's not licensed in this country, there is a lot of pushback sometimes and saying, well, why isn't it licensed? Am I a guinea pig? Are you like testing these medications on me? So that's kind of difficult as well. And, you know, that also takes a lot of education to understand and list the reasons to the client on why it's not licensed in Canada. It's a good drug. It's actually recommended in our Canadian TB standards as the first line of treatment for LTBI. So things need to match everywhere.
Absolutely, absolutely. And the meaningful participation of civil society, you guys have already spoken about that, but I would like to have your input into the number 7.
I feel like I can't speak for Kate on this one, so I'll just refer people to We Are TB and the work that they've started, which I think for our country has really been kind of the shining example. And yeah, Kate covered it so well earlier.
Yes, yes. Tina?
So there's been strong formal involvement in Inuit organizations and communities in developing Inuit-specific TB elimination plans.
Yes.
And there hasn't been so much for other risk groups, such as other Indigenous groups. And of course, I work with a couple of them in Northern Saskatchewan. Some initial work pre-COVID, migrants and new Canadians are not formally or structurally, though it may happen more often at the local program delivery level. Broadly, civil society advocacy around domestic TB has increased over the last 5 years, for example, with Stop TB Canada activities and several other civil society organization and networks are starting to become a part of the TB conversation. When I first started working in TB, you know, I was, you know, surprised at how much TB there was in the community I was living in. And then moving to another jurisdiction and finding out that TB was just as bad in that location as well. And I thought, why isn't anybody talking about this? So with my involvement with Stop TB Canada over the last couple of years, we've seen more of that advocacy in other groups. So we're really happy with that.
Yeah. So about the investments in TB, I mean, Treatment Action Group has been showing that. I mean, Mike has brilliantly spoken about that already. But how do we do that in the region? I mean, I don't want to be repetitive, but would you like to point out something, Mike and Tina?
Yeah, so we know from research that we do each year on how much money is spent on TB research globally, that the figure has gone up. And for fiscal year 2021, the last year that we have data for, funding for TB research for the first time reached $1 billion a year. But this was only half of the $2 billion that government said they would spend each year. And so now what's happened is, because each year that you fail to spend what you need to, you have to spend more to make up that difference. The funding target for that Stop TB is put out is actually much higher, somewhere around $5 billion a year now needed for TB research. And I think this has to be a focus of the next period. We really need our governments to substantially increase their investments in TB R&D, especially for the development of a new TB vaccine, which, if we're serious about ending TB by 2030, has to be the tool that we use. And has been pointed out, although the US and Canada are leading funders of TB research, neither country has met its fair share target. And so we still have progress to make in this region. And we actually see, I would say, minimal investment from governments across the Americas overall. And I think that this is something that our region is really well positioned to contribute toward, and a conversation that I hope advocates in Anglophone, Spanish, Portuguese, French Americas take forward with our governments, because there's a lot of research capacity in this part of the world and a lot more that we could be doing.
Absolutely. Tina?
I didn't realize I was off mute there. Domestic funding for TB research exists mainly through Canadian Institutes for Health research, but not a significant focus or amount. Funding for rapid adoption of innovations could be a lot more faster and better coordinated. For example, for IGRA, mobile chest X-ray, routine universal molecular resistance testing, programmatic rollout of 3HP, also video DOT though that expanded a lot during COVID. A considerable variation between provinces where that's used as well. Canada also fails to meet its fair share contribution to TB R&D.
Yeah, thank you. And I think we have to push also the center like McGill, which is a reference center also globally for WHO about their investment, and to push that they adopt the same US measure to be focused on having every study carrying out a community advisory board. So that would be a great input. I mean, they have been, so I mean, we are carrying a study here in partnership in Brazil, in partnership with McGill, of the Federal University of Rio and HTB with McGill, and this has we created a specific CAP for that to discuss. But I think that your point is really well taken. And finally, to ensure that the TB prevention and treatment are protected against emerging diseases and epidemics, and still in the context of COVID-19, which we are not free from that. So how do we ensure that we don't see the impact that we realized in with the COVID pandemic? What's your perspective on that?
Yeah, it's so true that our TB programs and healthcare workforce were really COVID-19 first responders. And our TB clinics became kind of COVID clinics. Our TB expert machines became COVID test machines. That was true for me. All my COVID tests that the New York City government gave me were run on expert platforms and chest clinics that the city maintains for TB. And so we need to recognize that if we want to invest in pandemic preparedness and response, you know, one of the other high-level meetings happening, we need to train a TB workforce. It doesn't really make sense to train a pandemic workforce on a pathogen X when we could be building surge capacity to handle TB, bringing more people into the field, training them on how to do things like contact tracing, you know, bioaerosol safety, molecular testing, treatment counseling, all these things that were so necessary for COVID are skills that we can build today working on tuberculosis. And that's a workforce that then for the next pandemic will be available and highly skilled. So I think rather than think like, how does the pandemic preparedness benefit TB? It's more like, what do we need to do for TB today? That's really an investment in pandemic preparedness. And when we use TB programs in the future, and we will, how do we pay them back, you know, reimburse them for the work they've done on whatever that disease is? I think we need to think of that kind of financial compensation model to make sure that we don't lose funding and don't lose as much ground next time.
Absolutely. Tina?
It's just, you know, hearing others speak about their experiences. It's just, you know, it's the exact same thing that we've had experienced. You know, when COVID-19 was declared a pandemic, there was panic, and of course my TB team was approached, and, you know, how do you do contact tracing for respiratory illness? You guys are the experts, show us how, even though the diseases and infections were different. But of course my team was taken, and myself included, 7 days a week we were working on COVID. And as I had seen our TB numbers starting to increase, I was like, okay, I need my team back. So that was kind of a struggle to get them back. And again, too, we've had, you know, gene expert capacity in our communities prior to the pandemic. Nobody wanted to learn how to do TB testing. Everybody learned how to do COVID because they had to. Now that COVID's gone, it's the same thing as before the pandemic. So us trying to, you know, enforce and, you know, say that the benefits of having that immediate testing results within a couple hours, we're still working on that as well. So, I mean, there were all these resources and all this money that came out, you know, to provide shelters and houses and units for people to isolate them. Like, why can't that be done with tuberculosis? A lot of our Indigenous communities face overcrowding in units, 2-bedroom houses, up to 20 people in one house. So how can you properly isolate when you're living in a household with that many people, and usually poorly ventilated units as well? So, you know, there's a lot of work to be done, but having these discussions is really important, and will lead the way to hopefully, you know, getting more people on board, getting more funding.
Yeah, definitely. I mean, if we don't learn from the lessons from COVID, if we really don't learn from that, I mean, we'll be losing a huge opportunity. I think, like Mike underlined, I mean, the preparedness has to be really done. I mean, we are still far from that. So we are running out of time. Actually, we are already out of time, and I would like to have the final discussion just to underline from the participants about if there are the notes by Kate, Tina, and Mike were well taken about the statements, but anything that you would like to hear, and any point that you would specifically think about the high quality people-centered care, how we can assure that in the next statements. I'd love to hear from you guys. The floor is open for the speakers and the participants. Can participants open their mic? Belkis or Monica? Can we open all the mics so that people can feel
Open
free
all
to
the
come?
mics, do you say?
Yes, let's open all the mics, so because we are
Let
in
me
the
check
final
if I
moment.
can do that. I don't know if I can open all the mics. Give me 1 second.
Because then we would love to hear from the last points. Yeah, but people feel free to write any
No, but
point.
excuse me, they can open their mics if they want.
Okay, if you raise your hands, I mean, we can open your mic, but feel free to drop a line on the chat box if you prefer, about the points which are on the screen. So the commitments and statements that you would like to see, and how to make sure that high quality people-centered care is guaranteed for people affected by TB. Okay, it seems that people are already tired. Oh, Eva, please open your, can we open the mic of Eva?
Good afternoon, everyone. First and foremost, I would just like to thank all of the presenters. This was such an amazing and enriching session. Thank you so much for inviting FPAT. And I really look forward to see how we can realize a lot of the commitments and a lot of the ideas shared. You know, with family planning, our parent body is the International Planned Parenthood Federation. And as part of our new strategic plan, we center a lot on client-centered and people-centered management. And this is important because it really puts to the center and at the core those we serve. And I just want to ensure that when we talk about people-centered and client-centered, is that the absence of support we should not have the absence of support. Being people-centered and client-centered not only means placing persons at the foremost and ensuring that their voices are heard, but ensuring that there are the relevant support systems and framework to ensure high-quality people-centered care. And I think that that's an important element, that we need to ensure that the support systems, the referral networks and frameworks are a part of that approach and strategy. And it is within that framework and approach that communities and civil society can contribute to forming and creating a people-centered care. Thanks.
Thank you so much. This was really brilliant. Thank you. Anyone else would like to add? But this was really super good to hear. Thank you so much, Ava. Any other comments? Last final comment or a statement or remark that people would like to make? Don't feel shy. Otherwise, we can finally finalize our session today. I mean, I think this was super rich and it was really amazing. I wish we, I mean, although it was really great to see, to have this conversation in English in separate, and obviously it goes easier if there is no translation. I would love to have this conversation that we can all together have our perspectives shared in the region. So in terms of next steps, I'll try to provide you for the presenters. I'll try on this Thursday to present a draft of what we have discussed today for your input. And PAHO will publish the results of this consultation, of the first consultation, which has run in Spanish and Portuguese, and the second version, of course. But and obviously these regional consultations are being shared with WHO for the reason that this has been an initiative from CSTF. We would like to draft a joint statement and we'll circulate to you who have participated for your input as well. I think it would be fabulous if we could have an American continental statement, joint statement from our civil society, a strong one for the civil society hearing the multi-stakeholders. Actually, it's broader than that, than civil society only, which is going to happen in early May in New York on the 8th and the 9th. So it will be great, and I'll try to circulate that next week so that we can start drafting that and having a strong statement. So we try to push that, and PAHO will be crucial to help us making that possible. So I would like to thank you immensely for your participation, and this was a great session. I thank you, PAHO, for holding this, and I thank each one of you for your input and participation. Thank you so much. Obrigado.
Thanks, Ezio.
Thank you.
Thank you, Ezio.
Thank you so much.
Bye.
Thank you, Ezio.
Thank you.